lower was the 1.5 T star. So with this images, I think it's possible to diagnose most of the situations. Field versus speed, which was done in the almost some of the images which have been acquired before. I'm just trying to show the examples. And we have recently started doing images on the mobile MRI system. So these are the sequences that are available currently, and apart from except the SWI, the T1s, the T2s, the flare, the diffusion ADC, these four important sequences are available in the MR. And this is all made possible with the help of the improved AI-based algorithm. So I will stop here, and then they are provided with the iPad where the images are immediately displayed at the bedside. And with the remote radiology sitting, I think these images are pushed to the integrated PAC system where immediately report can be generated. So I don't want to take much of a time. We can have a lot of discussion during the panel, I think, discussion. So I will end here. Thank you very much. But yes, there is a lot of other applications in the neuroradiology and neurointervention, especially in the terms of the stroke, where I think the stroke aspect scoring is very important. An aspect of 5 and above and aspect score of 5 and below makes a huge difference in terms of the outcome, whether to intervene or not to intervene. And here this aspect scoring is done with the AI-based algorithm. At the point of time, there is one AI-based algorithm available. So that makes it very prohibitively expensive. It's not widely available. So we need to work on these areas. And the second important thing is the imaging algorithm for epilepsy program, because epilepsy, there is a huge spectrum of disorders that can be a causative factor for the epilepsy. And if you identify a lesion and characterize it morphology with the help of the AI-based tool, I think it's another way to make utilize the AI-based protocol. And the most important thing is that sometimes in epilepsy, even though we have an epilepsy, the routine MR imaging may be totally normal. And here lies the role of AI, especially if you take the use of the ASL, the beta MR fusion. I think the AI can help in minimizing the MR negative cases. So with this word, I'll end here and stop here and take the questions. Thank you very much.
Thank you, sir. It's really great to see how AI is actually changing the field of MRI. I'd like to turn with this to Professor Raju Sharma. Sir, could you please share your thoughts on challenges of AI in radiology?
Yeah, thanks, Virender. While we've heard so much over the last 2 days regarding the advantages of AI, especially in the field of radiology, which is ideally suited, there are a lot of hurdles on this road and many challenges to be encountered. One of the foremost challenges is this kind of black box approach of AI, which creates a trust deficit with the physicians. When we do a multidisciplinary discussion with clinicians, they always want to know why are we giving that diagnosis, why that particular diagnosis is there in that patient. We need to explain why. AI algorithms don't do that. They don't tell us why they are making a particular diagnosis, and that, I think, creates a trust deficit. Another major hurdle is the fact that you need a lot of data to train your algorithms. Radiologist time is very precious, and good, clean data with annotation is a rather rare commodity, at least in our country. It's very difficult to generate that data. Then, of course, there are multiple other challenges. One of the foremost challenges is that you need to seamlessly integrate the AI algorithm into the workflow of the radiologist. If he has to use one algorithm for nodule, one for pneumothorax, one for fracture, he's never going to use it in the first place, because that is actually increasing his workload rather than facilitating his workflow. So you need to have an algorithm which is seamlessly integrated into PACS and which does all these tasks in one go, which is again easier said than done. And then there are multiple issues relating to data privacy, cybersecurity, governance, regulation, medical legal importance, which we'll discuss as we go.
Because the point you have raised is one of the last point is medical legal liability. Sir, could you please explain on further what it means with AI?
So currently the jury is still out on who's responsible if the algorithm makes a mistake. Obviously the medical legal responsibility continues to be of the physician. The physician has to validate the report. If the AI algorithm goes wrong, you cannot challenge the AI algorithm or the company which has made that algorithm. So far at least the responsibility, the medical legal responsibility continues to rest with the physician or the radiologist who is integrating them or even validating that.
Sir, with these challenges and these medical liabilities, could you share your experiences with practical use of AI in?
Well, I don't mean to say that we are not using it. We are using it in every possible step, but we are just aware of the challenges. So the role of AI in radiology comes right to the point when you are scheduling a patient. AI algorithm can look at the EMR and can prioritize the booking for that patient. Then it can help the radiologist to prioritize in what order those scans need to be read. You know, a stroke will get the highest priority. You should read that before you read low backache MR, and that can be done by AI algorithms. The third interesting experiment that we have tried, similar to what Shailesh was talking about, in a project with the University of Michigan, we have put a low-field magnet in a rural area. We have put it in the Pallabgarh rural facility that AIMS runs. We have a 0.55 Tesla magnet there, and that also uses a lot of AI algorithms to improve the image quality. So you can do what is called an accelerated MR with a very short protocol, and then improve the quality by using AI. There are multiple algorithms which improve image quality. We are also trying out an algorithm for triaging chest X-rays, where we do close to 1,000 chest X-rays in a day, and it's impossible to report that. We don't have the kind of bandwidth that we can report those. So we use an AI algorithm which helps us to triage the normal X-rays from abnormal ones, and only the abnormal ones get read. The normal ones get reviewed only if there is a clinical response.
Thank you, sir. With these challenges and how it is working in normal radiology practice, I would like to turn to Professor Ramesh. Sir, could you share your views how some of these challenges which Professor Sailesh and Professor Raju Sharma told could be addressed while you develop algorithms, while you develop AI and implement in the workflow?
Professor Raju has Professor Raju has mentioned many challenges, but I am talking about how AI community is working on this. So first I will be talking about if you are using deep learning models. If you are using deep learning models, definitely you require large NLP. So our lab is working in the direction of working on light video, where we can require lesser number of samples annotated data, and it can be better. So we are working in two directions. One direction is that we are not using pathway of deep learning model. There is another category in machine learning which we talk about unsupervised learning, where even if there is a single image, we can do image segmentation, MRI segmentation. So that is one. And then we are working on how we can develop, instead of having deep learning models where billions of parameters need to be done, can we have lesser number of parameters? So this is one. Second, I appreciate the concern that at present your doctors looks into that if you are saying that this is a case of stroke or PT or anything else, they are able to validate based on certain, you can say, image degradation or some clinical symptoms. These days, the AI community is also working in the direction of explainability of the model. That if your AI model is telling that this is the case of stroke, or this is the reason of reason, okay, they should be able to backtrack and can tell that this is, they are able to tell because of this particular reason. Okay, so it's not the earlier situation where we used to consider all these AI models to be black box models. But now it can be explained, and there are many such theories and applications again. Okay, I think third important point which I would like is we actually are facing problem. That is data is, and data only from one particular hospital is there. So it's not giving the right picture. So heterogeneity is also very important. Okay, so from different demographic. So what is the way to get this done. Okay. So if there can be some kind of collaborations from the different hospitals, and this data can be available to AI community, I think in some or another way, AI community can complement. Definitely, AI community cannot replace the doctors, but they can complement. Last, I would like to highlight that there is one approach which can be used where the concern of privacy and ethics and cyber security and other things can be taken care. And that is your federated learning. So in federated learning environment, we are developing models where the data will be available in a different sites. We don't require the data. So the initial models will be trained at individual sites, and then they will, you can say there can be a discussion, collaborations, and then the other models which are working at the client level they will get. So I think with time, definitely the two community, we are going to come closer to each other like this platform, and in some way, together we can help with this. I think with this,
Yeah, I think that's some of the problems can be solved with development and research. As far as the neuroimaging is concerned, I would like to turn to Professor Tapan. So, what would you like to, or how would you like to implement in neuroimaging, especially like say, if the MRI is being reconstructed from 1.5 to a low contrast, low field to high field, and so on, and also with diagnostic capabilities?
It's a very good question. So, first of all, let me highlight that all of a sudden why we all are interested in AI. Because what I believe that AI, basically we need to see that where we are not capable of, let's say being a human or being a human observer or a physician, where we are not good. So if you look at the human and the machine, there are two most important reasons. That's why we all are interested in AI. First thing is we want the results as quick as possible with higher accuracy. This is the first thing. Second is, if I talk about the human nature, the human brain can get easily tired. Let's say if you are doing the repetitive job, so the brain will automatically get tired and it's about to do the mistake, right? So this is one of the negative side of the human brain. And again, when I'm talking about the speed and accuracy, there the speed of the machine is faster than the brain because of the electrons, because you know that the machine, the electrons carry the current, and in the brain, the ions carry the current. So if you look at, the machines are faster compared to the human brain. So because of this, we all are interested in AI. So coming back to this AI and imaging, because you know that, let's say I'm giving a very simple example. Let's say if I want to diagnose epilepsy, let's say you are recording the brain signal from, let's say, 129 sensor or 64 channel sensor, and you get huge amount of brain data, the brain signal. Hardly you can make out of, let's say if one trained neurophysiologist look at this signal, it will take many hours if they will look at each and every sensor, right? But if you will apply this AI, it can do in fraction of second. It will tell the neurologist, please look at this section and find out that this is my analysis, and then the physician can see and confirm the cases, right? So here the question is again, being a human observer, maybe, if somebody will look at this data page by page, then they are about to commit the mistake. But machine, because this is machine, it will not do the mistake, right? So the challenge is, just like when you are asking this question, that when we are getting the images from different scanner, of course, this is a big challenge because when we make the model, let's say I train the model with some sort of data, and then we always tell that the image should come from the similar kind of setting. Let's say MR, what we call the MR physics. We tune many parameters, and based on that we get also different kind of images. So again, the AI cannot do the magic over here. So this is up to us that we can, only what we can do, we can train our model in such a way so that it can handle the data from maybe 1.5 Tesla, 3 Tesla, or 9 Tesla. So this is completely up to us that how we are going to make the model. So when we are talking about say AI imaging, radiomics and metabolomics, so I look at this problem, this AI problem, in a bi-directional way. So one way is just working on this biology or on the health kind of problems. Can we understand how the human being, our intelligence is developing, and then can we infer those kind of things in AI and vice versa. So I'm giving one example. So as I work on the children of the blindness, so what we found that the eye in the actually when we restore sight to let's say 20 years old person, we found that they are good in color perception, but they are not good in grayscale images. And then what we found that oh, why this is happening? Then we have tried to, when we are trying to understand that why this is happening, then we found that okay, let's see how the AI is doing. Then we trained the AI with only with the grayscale images, then only the color scale image, and then initially starting with the grayscale, we went towards the color scheme, and the other way, starting with the color scheme, we went to the grayscale images. What we found, when we trained the AI model with this kind of images, we found that the model which is being trained with grayscale first and then the color scale, that is becoming more robust of any scenario. And if the model is trained with color images, then they are not robust, just like the grayscale and the color image training. That means when we found that when somebody starts seeing the world at the age of 20 years, that they are good in color image perception but not in the grayscale, we found that this is okay, this is how our brain learns to see. That means, we are all exposed to this, this world not in this colorful the way we see today. We start with the grayscale and then we transform to the color term. So likewise, from here, what we found that many times we say that okay, if I want to build a model which can recognize the objects in the way, always feel okay, let's train with the color images. But no, this is not the right way. You need to train with the grayscale and then the color images, and then it will be much more robust, right? So likewise, here when we are talking about, let's say, here AI imaging, radiomics, metabolomics, we call it multi-omics kind of modeling. That means initially for any kind of prediction or to understand any kind of disease progression or the nature of the disease, so we try to do all of this together and then we create a model. So finally the objective is, because you know that nowadays when you go to the hospital, the doctor will recommend you do this test, that test, this test, and multi number of tests, and where the patient need to pay huge amount of money and also the time. The question is, from this multi-omics model, can we come up with a model where just I'll enter or I'll throw only one data, and from this one data, I'll be able to predict or categorize the problem or the things. Let's say I'm giving one example. Let's say tumor. You know the tumor is a heterogeneity problem. The tumor, the nature is different, right? Let's say if I'll do, let's say I'm talking about metabolomics. Metabolomics means to understand that what are the metabolites present, right? In the same time, I'll take the images of that tumor and then I'll correlate which features of the images are correlated to these metabolites. So maybe in the next time, if I'll create the model, and if I'm getting some tumor, instead of doing the invasive, because you know that nowadays we are going towards more non-invasive kind of techniques. So from these images, people just take the non-invasive images. From these images, can I backtrack and tell which are the metabolites present in this tumor? Then I can easily understand the tumor, right? So these are actually, the most important thing is that we need to understand what we are going to do and where we want to deploy AI, which will help us just to speed up our process and also help us to take our decision in a better way. So of course in the healthcare, the last thing is that always we need to keep human in the loop of all these things, whatever they will do, but finally we need to take the consent from the human or the expert, then only we can do the job in a better way.
Thank you, Dr. Apan. You brought into discussion two more topics. One is radiomics, which was supposed to be into the title, and the metabolomics. Dr. Uma is having a first-hand experience of working in metabolomics for so many years. So one of the dream of any researcher is that the tool he or she works would like to see it working in the clinic. Other AI methods are there, in clinic, but let's hear from her what's her view on whether metabolomics can make into clinic or how it will go on. Dr. Masha.
Thank you, Dr. Virendra. So, Dr. Tapan has already introduced the metabolomics here. So, first I would like to tell that what all we have been working. So, I would, maybe I'll take up one example. So, I am not only working on metabolomics, I am looking at the disease pathophysiology from three angles. Like in the psychiatric disorders, I have been working on depression, schizophrenia, and general anxiety disorders. So I take the example of major depressive disorder. In this, what we are doing, we are looking at the brain, how the structural changes are happening in the brain. We are seeing what is happening here from the neuroimaging levels. And then we are, in the same patient, we are trying to do the localized MRS. Localized MRS means we are getting the biochemical levels from the different brain areas there. So we have chosen those two areas, hippocampus and ACC. So those two areas are basically the part of the limbic system which affect your emotional system. So we are looking at what is happening at the biochemical level. So when the disease pathophysiology, when pathophysiology is happening, some disease is happening in a system, that means there are some changes in the structural level, some changes in the biochemical level. Then at the same time, in the same patient, we are looking what is happening in the peripheral metabolites. So how these three things are connected, I will, what Dr. Tapan has said. So the similar kind of things we are trying to see how these things are connected, how these parameters are connected. So I'm basically from the Department of NMR. So we have three kinds of system, MRI system and the NMR system, where we can do the metabolomics. We can find out a lot of metabolic parameters, a lot of metabolites from the biofluids like blood plasma, urine, and even the CSF, or we can even take the tissue samples. So we can find out the metabolite levels from there, and we can say that what are the metabolic pathways that are altered there, and what are the metabolites, those are altered between the two kinds of system, like one is a normal person and one is the diseased person. So we can use those parameters as a biomarker. So we have three different kinds of data sets here. One is the metabolites, and another is the neuroimaging parameters, like the different brain volumes we have. Then another is the biochemical levels at the localized regions. So how we can use all these three parameters to understand the pathophysiology, what is happening there, like that. And this is where we can combine the integrated approach to understand what are the biological changes happening in the human beings when somebody is turning into disease. So this is where I feel the AI can be used in this, and this is where what Dr. Tapan was saying, that this is where our human brain can get tired, that how to connect this metabolic pathway, how to connect that metabolic pathway, how to relate it to the structural changes, how to relate it to the biochemical changes at the brain. And in fact, in our study, one of the paper will be out in couple of days. So we have found that there is a significant correlation between the anatomical changes that are happening in the brain and the biochemical changes that are happening in the brain. And even significant association we are finding with the metabolome of the blood metabolome and the urine metabolome there. So even sometimes I feel, in fact, many a times I feel that I should go to the clinicians in our institute, that when these metabolic changes are happening or peripheral metabolic changes that we are finding, can we change the metabolism of the human being? Can something can be done? Like we are finding that BCA metabolism is lower in the patients, and there are other metabolites which are lower. Is there a way to change those metabolisms by giving some kind of medicine or some kind of nutrition thing? So maybe this is where we can have a look at all these things.
Thank you, ma'am. We are already little over time, but before closing, I would like to ask each of the panelists, first Professor Sailesh, Sir, any last message to the development and researcher community for AI in radiology?
So I think there is a lot of knowledge gap between the healthcare givers and the providers, I think. Some of them are being addressed by the government initiative, but we need to do something more, especially the areas where the outcome is time sensitive. In a very acute emergency, for example, acute stroke. So last year we conducted a study to find the prevalence of this stroke in India, and what we came to know that 1.7 million patients had stroke every year. And how many of them were getting treatment? So it turned out that only 4,000 underwent mechanical thrombectomy, especially when there was a large vessel occlusion. So what were the gaps? The gaps were on many fronts, like lack of trained manpower, infrastructure, urban-rural divide, remote patient living in a remote area, not having transportation means to reach to the most comprehensive stroke center. So here I think with the help of robots and other things, if there is no manpower there, at least whether we can have and ship the patient to the nearby secondary stroke center, not if not a comprehensive stroke center or a primary stroke center, where I think with the help of the robots, we can guide and remove the clot. So that is one area where I think the AI algorithm can help us out. The other thing is that sometimes stroke is not known to many people. What is stroke basically? So in our setup, usually people believe that stroke is not a treatable condition, and that generally delays the attention, delays the diagnosis, and by the time the things become worse, the brain is already, I think, necrotic and beyond salvageable point. So here I think AI can help us out in removing some of those knowledge gap challenges and difficulty in recognizing the stroke, right? So what matters here is whether stroke is large vessel or small vessel. Large vessel occlusion, if they are not treated within the finite period of time, like for example 6 hours, then we are reaching to a point where the smaller infarct will keep expanding into the area which could have been easily salvaged if there was intervention at the right time. So here I think AI can help us a lot by identifying large vessel occlusion with the help of the AI-based tool, I think. So some of these areas which require, I think, urgent attention these are the areas where we can make a huge difference in terms of improving the patient's quality of life and the outcome.
Thank you, sir. Raju sir, any last quick say?
Very briefly, I think I would just like to say that AI is not going to replace the radiologist, but a radiologist using AI will perhaps replace the radiologist.